Hello guys, welcome to our channel. Today we will have a quick recap of arterial blood gas interpretation. If you would like to attempt MCQs instead, you can go through the MCQ video that we will be posting tomorrow. So let's begin. These are some of the aspects of ABG that we will be discussing today. It should be enough information to solve ABG related questions in the exam. So let us begin by discussing normal values. As we know, an ABG result also has other information available on it too, such as electrolytes, hemoglobin parameters, and more, so it is important to go through all of it in reality. However, for the purpose of this exam, I will be focusing only on that which will help determine the metabolic or respiratory component. Remembering these few values is extremely beneficial to help saving time in the exam, so totally worth memorizing. These are all UK values. Type of respiratory failure is easy to remember. Type 1 has one abnormality and type 2 failure has two abnormalities. Respiratory failure type 1 is defined as hypoxemia only, while respiratory failure type 2 is defined as hypoxemia and hypercapnia. Basically, the patient is getting tired and unable to expel the carbon dioxide from the lungs. This is dangerous and may warrant intubation. So ideally, if a patient has hypoxia, the body will try and wash out the built-up CO2. Be cautious of a patient who is hypoxic and having a normal PCO2, as they are tiring out and soon will have a type 2 respiratory failure. To understand how to interpret ABGs, it is necessary to recall the physiology of it. Not precisely everything, but just that whenever an imbalance occurs, the acid produced by metabolism is quick to be corrected through three separate mechanisms which are interdependent on one another. One is the buffering system, two is the respiratory system, and three is the renal system. The buffering system activates within seconds and works through weak acids and bases. Carbonic acid and bicarb are the most important pairs of buffers. Respiratory system activates and causes changes in pH within minutes through ventilation. It is especially useful to compensate for changes in pH related to metabolic disorders. Renal compensation, on the other hand, occurs at a much slower rate and mostly useful to compensate for respiratory disorders, around 1 to 2 days for respiratory alkalosis and 3 to 5 days for respiratory acidosis, since changes in pH occurs through excretion or conservation of hydrogen and bicarbonate ions. A simple mnemonic to spot the disorder is ROME, respiratory opposite and metabolic equal, meaning that if the cause is respiratory, the carbon dioxide will move in the opposite direction to the pH. But if cause is metabolic, then the bicarb will move in the same direction as the pH. If the rule of Rome is not being followed, then compensation is taking place. So what's happening if the PCO2 is moving in the same direction as the pH? This is then a respiratory compensation for a metabolic cause. And what if the bicarb is moving in the opposite direction to the pH? This is then a renal compensation for a respiratory cause. We will not be going through an exhaustive list of causes here. It would be helpful to remember the pathophysiology so as to remember the various causes. So for example, anything which leads to an inadequate alveolar ventilation will result in a respiratory acidosis. Hyperventilation would result in a respiratory alkalosis as carbon dioxide gets rapidly washed out. Metabolic acidosis is caused by an increased acid production or acid ingestion. A decreased acid excretion by the GI or GU or bicarbonate loss can also cause a metabolic acidosis. The advantage of calculating the anion gap helps point to the likely cause. Acid production or ingestion would cause the anion gap to be naturally high, while a reduced production or increased excretion of bicarb would cause the anion gap to be normal. A decreased hydrogen ion concentration leads to metabolic alkalosis, such as that which is seen in profuse vomiting, since the body loses hydrogen ions from vomiting out gastric juices. Everything in bold are the most common conditions around which scenarios are designed. It can be a great help in confirming your answer to ABG interpretation if one can recall the acid-base abnormality to be expected in a particular condition. Compensation can be of three types, either uncompensated, partial, or full. Simply put, if a full compensation has occurred, then you would expect the pH to be normal, whilst the disturbance in PCO2 and bicarb reflects the mechanisms through which the body has been able to correct the pH. A partial compensation is seen as the pH that remains to be abnormal despite the body trying, as a result of which bicarb and PCO2 are both found to be abnormal. Whilst uncompensated means that the pH is abnormal, the body's mechanisms have still not kicked in to try and normalize the pH, commonly seen in respiratory disorders that present acutely, whereby the renal system may take time to correct the pH. Therefore, the bicarb is still in the normal range. I believe uncompensated in the case of a respiratory cause can be a bit of a confusing terminology, as it suggests that the body tried but failed to compensate, whilst in reality it could just be that it is uncompensated only because the compensation hasn't yet kicked in and will take time. It is also possible to have a mixed acidosis or alkalosis. I call it the double trouble, which means that if there is an acidosis, there can be both respiratory and metabolic components contributing to the acidosis. In the case where there is alkalosis, there can be both respiratory and metabolic components contributing to the alkalosis. Identifying it on the ABG is simple. You will observe that the PaCO2 and the bicarb will be moving in opposite directions to each other and not the pH. If this is confusing you, then you can follow the Rome rule. For example, in the case of an acidosis, the pH will be low. According to Rome, if the cause of acidosis is respiratory, then the PaCO2 should be moving in the opposite direction to the pH. So it will be high. And if the cause is metabolic, it should move in the same direction to the pH, meaning that the bicarb will be low. Since there is a mixed imbalance, both high PaCO2 and low bicarb will be seen. Thereby, both components will be contributing to the acidosis. In the case of an alkalosis, the pH will be high. According to Rome, if the cause of alkalosis is respiratory, then the PaCO2 will move in the opposite direction to the pH. So, we should expect the PaCO2 to be low, and if the cause is metabolic, it will move in the same direction to the pH, meaning that the bicarb will be high. Since there is a mixed imbalance, therefore both PaCO2 will be low and bicarb will be high, thereby contributing to the alkalosis. People have various methods of ABG analysis, and well, this is what works out for me. If you're used to another method, then that's absolutely fine and just stick to it. If you're someone who finds it a little confusing, then maybe this might help you. Step 1 quickly helps you get to half of the answer, which is whether it is acidosis or alkalosis. So if the pH is dropping, the more acidic it gets, and if it's increasing, then it is alkalosis. Step 2. As stated before, use the mnemonic Rome to help decide the cause. Compare the PaCO2 and bicarbonate in relation to pH. If the PaCO2 is moving in the opposite direction to the pH, then the cause is respiratory. But if the PaCO2 is moving in the same direction, then the cause is likely metabolic with a respiratory compensation. If the bicarb is moving in the same direction as the pH, then the cause is metabolic. And if moving in the opposite direction, it is a respiratory cause with a renal compensation. If a respiratory cause is confirmed by ABG, then there is the additional step to identify the type of respiratory failure. This we have already discussed before, so I'm not going to go into detail. If a metabolic acidosis is identified on the ABG, then the additional step is to calculate the anion gap to work out if the metabolic acidosis is due to increased acid production or ingestion versus a decreased acid excretion or loss of bicarbonate. You can calculate the anion gap if you would like. However, I will not be focusing on this as of now because it is not mostly asked in the exam. Step 3. A high base excess means that there is more bicarbonate in the blood, meaning that either there is a primary metabolic alkalosis or a compensatory respiratory acidosis. The opposite is true for a lower than normal bicarbonate. Step 4 includes identifying compensation, whether it is full, partial, or uncompensated. We will go through a couple of simple examples without scenarios. Let us follow the 4-step process and interpret the ABG. So step 1. Here the pH is low, so the primary problem is an acidosis. Step 2. A high PaCO2 is going in the opposite direction to the pH, suggesting the cause is respiratory. Since the cause is respiratory, let's look at the PaO2, which is low. Patient is hypoxic and hypercapnic, suggesting a type 2 respiratory failure. Step 3 can be skipped as base excess is not mentioned. Step 4, pH is low, so not fully compensated. It is uncompensated as the bicarbonate is normal. So this is an uncompensated respiratory acidosis. Here the pH is low, so the primary problem is an acidosis. The PaCO2 is low and moving in the same direction to the pH, suggesting that a respiratory compensation is taking place. Bicarb is low and moving in the same direction as the pH. This is a metabolic acidosis. Base excess is not mentioned and the anion gap cannot be calculated as sodium and other values are not stated. Lactate is high. This is a partially compensated metabolic acidosis. Here the pH is high, so the primary problem is an alkalosis. The PaCO2 is high and moving in the same direction as the pH, suggesting there is a respiratory compensation. Bicarb is high and moving in the same direction as the pH. The base excess of 15 is high and suggests that there is plenty of bicarb in the system, so there might be an ongoing metabolic alkalosis. pH is still high and PaCO2 is abnormal, so there is a partial compensation. The abnormality is that of a partially compensated metabolic alkalosis. Here the pH is high, so the primary problem is an alkalosis. The PaCO2 is low and moving in the opposite direction to the pH, suggesting the cause is respiratory. The PaO2 is low, confirming a type 1 respiratory failure. The bicarb is normal. The pH is still high and bicarb is normal, so this is an example of an uncompensated respiratory alkalosis with type 1 respiratory failure. Here the pH is normal but on the lower side of normal, so there was a possible acidosis that has now been corrected. The PaCO2 is high, suggesting there is a respiratory cause with a type 2 respiratory failure, since patient is hypoxic and hypercapnic. Bicarb is high, likely due to the renal compensation. The renal system has compensated for the disturbance, therefore the pH is now in the normal range. The abnormality is that of a respiratory deterioration with a renal compensation and a type 2 respiratory failure. Here are some exam tips that might be helpful. Some of these we have discussed and some of these we will be discussing when we do the MCQs tomorrow. So use room to identify the type of disturbance as described previously. COPD, asthma, PE, pneumonia, and sepsis scenarios are to be expected. COPD patients should never be given 100% oxygen when hypoxic, as they depend on the carbon dioxide as their respiratory drive. Anxiety-led scenarios resulting in a respiratory alkalosis are quite common, and often these scenarios mention that the patient has some sort of paresthesia. Also, differentiate between a pulmonary embolism and a panic attack by looking out for the PaO2, because both PE and panic attacks can cause a respiratory alkalosis. So the differentiating factor would be the hypoxia that we see in PE. This will be discussed tomorrow in the MCQ. Scenarios involving a respiratory cause may mostly be uncompensated, as it takes a while before the renal system can help buffer the abnormality. Try and go through the causes table in order to identify the most common case scenarios. And this would just speed up the process of answering questions, because it's quite helpful to know certain common conditions and their respective acid-base abnormalities. Thank you guys for taking the time out to listen. If you found this useful, kindly subscribe to our channel and share the video so others can benefit as well. Please check out the upcoming video tomorrow for ABG related MCQ discussion. We will have covered all possible ABG related scenarios.